All right, good afternoon. Thank you for joining me, and thank you for being a part of the GAP MASLD MASH Community Network. I'm Jeremy Davis. I'm an acute care nurse practitioner out of Shreveport, Louisiana. And tonight's topic of discussion, sponsored by Madrigal, is non-invasive testing. Again, here, this is who I am. I'm happy to join you this evening, and welcome, welcome, welcome. I greatly appreciate it. So we're going to discuss non-invasive testing. This is a QR code to record your attendance for this meeting. Feel free to capture this with your phone. We're happy to have you involved in our MASLD community network. So we're going to begin with a case study. We're dealing with Mr. Albert. He's a 65-year-old male who has obesity, who was referred for elevated liver enzymes with abdominal ultrasound that was remarkable for increased echogenicity consistent with steatosis. Now, he is considered a BMI of 29 kilograms, so we know that that's obese. Now, on his lab work, his triglycerides are 89, HDL 41, hemoglobin A1C 7.2%. ALT has been elevated for quite some time, and it's been in the 1 to 2 times the upper limit of normal range. Now, the good news is evaluation for other causes of liver disease have been negative. So, alcohol history, guess what? He's like, I don't drink. I hadn't drank since I was 20 years of age. As far as medical history, again, we've discussed that he has type 2 diabetes, hypertension, and hyperlipidemia. And on exam, he does have a little bit of fat, but he doesn't have any stigmata of advanced liver disease. And his body mass index, again, is 29. Now, things to consider when we talked about in a previous discussion regarding, hey, what are risk factors for MASLD? You know, 2 or more cardiometabolic risk factors can put somebody at risk for MASLD or MASH. So considering that he has steatosis on ultrasound, considering that he's diabetic with hypertension and hyperlipidemia, he definitely, and he's also a BMI of 29, he definitely has more than 2 risk factors for MASLD and MASH. Now, the key kicker is that somebody referred him because his liver enzymes were elevated, but we're understanding that's not always necessary, but kudos to those that do refer. So his preliminary diagnosis, he's got metabolic dysfunction associated steatotic liver disease. This is also known as MASLD. So let's discuss non-invasive assessment of liver disease as of 2025. And what you're going to find out is we have a whole slew of things that we can use in the community setting in order to assess non-invasive ways to look at liver disease and fibrosis. So imaging biomarkers of liver fat, you have ultrasound quantitative techniques, MRI studies, CAP scores, that's part of vibration controlled transient elastography, MRI PDFF, also imaging biomarkers of liver stiffness, shear wave elastography, vibration controlled transient elastography, and MR elastography. As far as clinical prediction rules for fibrosis, FIB4 fibrosis, this is something that is readily available within community setting. NAFLD fibrosis score and APRI, these are tests that you can do without any extra test that can be performed just in your clinic with just some simple labs that you check already. And then you also have proprietary serum markers for fibrosis. Enhanced liver fibrosis will be what we focus on. And as far as the other guys, CAP score, MRI PDFF, VCTE, and MRE, we're going to highlight on a little bit later. And then you have other combined rules that look at other ways that can kind of give you an idea, what are we looking like as far as not only steatosis, but fibrosis. So let's discuss the FIB4 calculator. Now, again, this is simple labs that you get in your community setting. You're looking at the patient's age. You're looking at their complete blood count. What are their platelet count? What's their AST? What is their ALT? And a FIB4 fibrosis score less than 1.3, it can exhibit a high negative predictive value for excluding somebody with advanced fibrosis with someone that may be at risk for MASLD or MASH. Now, granted, if they have a higher score, such as 2.67, or between that and 3.48, then guess what? You may need to consider, hey, let's think about sending this guy send this individual out for further evaluation. We have in the community gastroenterology that does some hepatology, but you also have hepatology within gastroenterology, where hepatology just sees most of the hepatology patients. So you have good opportunities to non-invasively look at this score to understand what are the risks for fibrosis and when can and should I refer my patient for further evaluation. So another blood marker, biomarker that we look at, and I know that within our practice, we utilize this often with vibration control transelastography that we'll discuss later. This is called an enhanced liver fibrosis test. This measures 3 direct markers of fibrosis and has good diagnostic accuracy for advanced fibrosis. So if you have access to this test, this is a blood test that can be obtained in your clinic through your lab study, lab centers, and it can give you an idea of, hey, is this person at risk for fibrosis or not? So other non-invasive assessment of liver fibrosis, transient elastography, that's going to be through FibroScan, shear wave elastography, that could be ultrasound elastography, MR elastography, as well as 2D shear wave elastography. So we have all these different options that uses ultrasound waves that can help us understand how much fat's in the liver, and for some entertainment, fibrosis as well. What we understand is that shear waves are utilized in order to measure fat score as well as fibrosis. The stiffer the liver, the more likely chance of fibrosis exists. And again, keyword non-invasive, meaning, hey, you don't have to get them a liver biopsy to figure this out yet. So let's touch base on vibration control transient elastography, or VCTE for short. This is a non-invasive quantification of 2 physical biomarkers of the liver within a 10-minute examination. Now, granted, from experience with our operators in our practice, we use this machine often in combination with enhanced liver fibrosis testing. The opportunity is that sometimes you're going to have a subset of populations where this may be very difficult to do. Sometimes, depending on the patient, depending on the other circumstances regarding the patient at time of evaluation, it may lead to a little bit longer than 2-minute examination, and it really depends on operator experience and the patient as well. But the main goal is liver stiffness. So CAP, you're basically looking at steatosis, and with another score, it's called kilopascal score, you're going to look at fibrosis assessment as well. So with considerations for this test, do you have at least 10 valid measurements? Now, I know that in our practice, we've had our operator do a test and they're like, well, only got 3 measurements. Well, you're not going to really get good quality imaging or an interpretation just off of that. So at that point, if that's something that happens, then you might want to consider an alternative form such as MR elastography if that's available, but sometimes the dreaded liver biopsy may be recommended. How well is the IQR? So basically this measures if the median is less than 30%, then you're going to have a good quality image. If you look at this picture of the parallel shear wave margin to the left, this is what you want to see. But a lot of times this is what you won't see. Sometimes it may look like you have QR codes just hanging out all in that shear wave margin, which doesn't really give you a necessary good result. But this is a perfect example of what you want that shear wave margin to look like. Patients ask all the time, hey, when you did that test, did you get a good picture of my liver? And the answer is, well, we kind of got a representation of it, but we didn't take a snapshot of what your liver looks like. Kind of like, the ultrasound did a better job of that. So image quality is very important. If you see the example you have before you, that's a really good image quality. What was the success rate to obtain 10 measurements? Again, at least 10 measurements are necessary. Sometimes there's an opportunity that the operator is going to be like, I'm going to try harder and I'm going to get more than 10, but he or she can take the best 10 out of that and come up with an average to give you an average kilopascal and cap score. And then also, is the operator experienced? That's very important. When I first trained on FibroScan, when we first had it available for our Hep C clinic and even in our research center before it became available for everyday clinical practice, let me tell you, it could be a little bit tricky. It can be cumbersome, but the one key experience is that the more you do it, the better off you get. So if you happen to be in the community and are the one doing these FibroScans in the community-based setting, the more you do, the better off you get. And so thankfully, I can tell you within our practice, we have one operator that has been doing these for us for many years. And so we like consistency with that. And then also in our research center, we do have operators as well as backup if need be. But really good test, non-invasive, gives you an opportunity to non-invasively figure out scarring and fat. So what are the limitations? Well, if your lab value suggests a score greater than 100 on ALT or AST, that can suggest some acute inflammation of the liver. So this may influence liver stiffness, cholestasis, we know can do that as well. What about the patient? We typically recommend that they fast 3 to 4 hours before the test. However, some patients are like, well, I forgot and I got hungry, so I ate. Well, that can definitely contribute to liver stiffness. What about alcohol use? Now, I hadn't had anybody come into my practice and say, hey, man, I felt really nervous about that FibroScan test, so I just drank a fifth of vodka before I showed up. I hadn't heard anybody say that, but we know that alcohol use, again, can promote increased liver stiffness. What if they're morbidly obese, their BMI greater than 35? Well, the thing is when you're dealing with that, you have to understand that the distance between the liver and the surface of the skin may be variable, and that can increase liver stiffness within the liver when that FibroScan is done. So there may be some overestimation on that. The same goes for ascites and liver masses. You wouldn't believe it, but guess what? Fluid can encroach in between the surface of the skin and the peritoneum and get between the liver and the rib and what have you, and that can create liver stiffness as well. So you have to be mindful when you're scheduling or planning a FibroScan. If you have access to that, understand that if they're over a BMI of over 35, if they have ascites, if there's a known liver mass, then you have to be prepared for the opportunity of, hey, we may have an overestimated finding. If that's still implemented just because you want to see what it shows, then no harm, no foul. But the opportunity is you want to make sure that you're aware, hey, I might be happening to have an overestimated reading. So that way you can mentally prepare for what's the next step to understand this fibrosis better. So MR elastography, this is a great technology, but sometimes it's really hard to get accessibility to use it. I know that within our community in Shreveport, Louisiana, we have a hospital setting that allows us an opportunity to use this. We typically will implement this primarily in our research setting if we're looking for CAP scores, if we're looking for steatosis, things to consider. If a BMI is greater than 40, probably not the best candidate. And that's not to say that they can't fit in the machine, but sometimes it affects the quality imaging of the study. Also, iron overload can definitely affect what you see as far as CAP score. What if they have non-MRI compatible implants? That includes, hey, I had a pacemaker or I had neck surgery, I have screws or something like that, or anything that might be around the area of concern. You might want to consider not using that. Some patients are claustrophobic. So if they're claustrophobic, then guess what? They're not going to really stay still. They're likely going to have a poor quality image, and we just wasted our time. What about hepatic congestion? Again, that can overestimate a lot of different things. And then also, the main thing is, despite your best wishes on what you want to do, a lot of times insurance may get in the way. There may be cost constraints, but you got to keep all these things into consideration. All right, so this is a chart just summarizing non-invasive biomarkers, looking for fat and fibrosis and MASLD and MASH. And what we're seeing is that FIB4 calculation, again, the rule out cutoff points, this is a good slide to think about. If they're less than 1.3, or they're, that's low risk of any fibrosis. If they're greater than 2.67, then guess what? There's an opportunity that they're at risk for fibrosis, and you might want to refer. As far as low predictive value, it's less accurate if somebody's greater than 65, or if they're less than 35, you may have a little variation as far as the scoring. But the good news is anybody can calculate it with basic labs that's obtained just from routine visits. You use routine clinical data, so it's not costing the patient anything extra to come up with a score, and it has a really good predictive value. As far as enhanced liver fibrosis testing, if the score is less than 7.7, then there's low likely chance of fibrosis. If the score is greater than 9.8, again, that's the time you want to consider referring for further testing or to gastroenterology, hepatology. The key limitation on this, it is a send out test, so therefore it may cost the insurance or cost the patient money out of pocket, depending on how it's ordered. But the good news is it's pretty predictable as far as the benefit of doing that. So you have a good predictive value that this is accurate. As far as non-invasive imaging fibrosis biomarkers, vibration controlled transient elastography, you're looking at kilopascal score with that, as well as the MR elastography. If the kilopascal score for the VCTE is less than 8, then less likely the risk of fibrosis. MR elastography is less than 2.5. But conversely, if somebody has a kilopascal score of greater than 12 versus a kilopascal score of greater than 3.6 on the MRE, then the likelihood is they probably are at risk for advanced fibrosis, and you want to make sure that they're being followed appropriately. Now, again, with the transient elastography, there's different confounders that limits the use of this, and also you want to make sure that whoever's doing the test is pretty experienced in what they're doing, so you're not going to have any skewed results as a consequence. Now, point of care, look, you get it done then and there, in and out, 10 to 15 minutes, you know what you know. So it's a very good strength in order to consider this, and it has a really good predictive value. But again, keep in mind limitations from different factors that we discussed earlier. But if you need to use it to say, hey, I want to see what it does, you're not hurting anyone or anything by doing so. As far as MR elastography, it is costly. It's not widely available. But the good news is if you do get a chance to use it, it's very accurate with very few confounders. So let's go back to Mr. Albert. As we recall, this is a 65-year-old Hispanic male, BMI of 29, has comorbidities that puts him at risk for MASLD, and we really wanted to understand, what his degree of fibrosis was. So again, we discussed different ways of looking at non-invasively ways to measure fibrosis, and for Mr. Albert. So again, baseline diagnosis based on what we know: metabolic dysfunction associated steatotic liver disease. So when we look at lab, again, ALT, AST platelets, we calculate a FIB4 fibrosis score. His FIB4 fibrosis score is 2.2. Again, this is an intermediate range. So again, remember, if it's greater than 2.67, the risk of fibrosis, if it's less than 1.6, which we'll see coming up soon, then the opportunity is less likely risk of fibrosis. But because of its intermediate state, the opportunity is we need to do more testing in order to determine if we can figure out how much fibrosis he may have. So again, on this chart, we're basically laying out, and again, I would tell you to refer to this. This is a combined chart looking at non-invasive testing for patients with MASLD. It's the AGA clinical pathway flow chart, which is concise with AASLD. So again, Mr. Albert is intermediate risk. What should we do next? If we look at the chart closely, then we understand, hey, it's time to get liver stiffness measurement. So he gets a FibroScan, kilopascal score is low, 6.7. So what does that mean? What do we do for this patient? Well, we're going to discuss lifestyle modification, Mediterranean diet, increase in physical activity, weight loss of 5 to 10% of total body weight. As far as metabolic disease management, we know he has hypertension, hyperlipidemia, type 2 diabetes. So we are going to rely on our medical teams. This is a team effort. So cardiology, endocrinology, primary care, gastroenterology, hepatology, we all play a role in this arena for taking care of Mr. Albert. And again, the main goal of this is we understand he does have liver disease. He does have a risk for fibrosis progression. However, because of his low risk, the main thing based on this cohort and this guideline, you can reassess non-invasive testing in a couple of years. The sincere hope is that if he happens to see something that's changing in his labs, that collaboratively speaking from the healthcare model and the team, that if we need to reassess sooner, then we're happy to do so. But based on guidelines, you're mainly favored to reassess in a couple of years. All righty, so that concludes our presentation. Again, Madrigal has sponsored this event. So if you look at the QR code, you can visit the GAP MASLD MASH Community Network to view Madrigal MASH Disease State Education and Madrigal Resdifra promotional program. Again, thank you very much for this opportunity. It was great discussing with you how we can look at non-invasive testing in order to understand our risk for patients who have MASLD that may have MASH, and how we can appropriately stratify that in order to get them optimal care that they need with our wonderful healthcare community. Thank you again so much. It's a pleasure being with you. Again, I'm Jeremy Davis. If you have any questions or answers, please feel free to reach out. I'm always happy and readily available. And feel free to come navigate the community network, where I, amongst other providers in our great state of the United States, are readily available and accessible for anything that you may encounter in your community. Thank you again, and good night.